Hello and welcome everyone. Today's journal review is on influence of socioeconomic status on functional recovery after ARDS caused by SARS-CoV-2, the multi-center, observational RECOVIDS study. Published in ICM last week. Severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, leads to hypoxemic pneumonitis. 5% of symptomatic COVID-19 patients needed ICU admission. 50 to 70% of those in ICU required mechanical ventilation due to ARDS progression. COVID-19 ARDS survivors at risk of functional impairment and new disabilities. Causes: severe pulmonary infection, multi-organ dysfunction, and prolonged ICU stay. The problem statement is, majority of COVID-19 cohort studies focused on non-ARDS patients. Limited knowledge on respiratory sequelae in ARDS survivors post-ICU discharge. Lower socioeconomic status linked to higher mortality within 30 days of critical care admission. COVID-19 pandemic exacerbated health disparities in socially disadvantaged populations. People in low socioeconomic areas. Less likely to get tested, but higher chances of positive results, hospital admissions, and fatalities. The RECOVIDS study aims to understand how socioeconomic status influences respiratory recovery in COVID-19 ARDS patients. Long-term consequences of COVID-19 ARDS and its relation to socioeconomic factors. The role of socioeconomic status in predicting lung function in adulthood and recovery from COVID-19 ARDS. The methods, study design. It's an observational, multi-center cohort study conducted across 30 French centers. Patient inclusion: adult ICU patients with confirmed SARS-CoV-2 infection. Required initial phase chest CT scan. ARDS diagnosis as per Berlin 2012 definition or received high-flow nasal oxygen, details specified. Exclusion: certain walking limitations, chronic respiratory insufficiency, non-affiliation to national health insurance, legal protection, and more. The procedures: screening at ICU discharge and during post-ICU hospitalization. Follow-up, 6 plus or minus 1 month post-ICU discharge, included clinical exams, 6-minute walk test, pulmonary function tests, chest CT, and more. Social deprivation assessment: individual level, EPICES score, and ecological level, IRIS using the French European Deprivation Index. The primary outcome was presence of lung sequelae 6 months post-ICU discharge. 1. Alterations on PFTs, DLCO and/or FVC less than 80% of theoretical value. 2. Oxygen desaturation during 6 MWT. 3. Fibrotic-like findings on chest CT, details specified. CT interpretations by 2 experienced radiologists. The secondary outcomes were persistence of dyspnea, PFT results, and muscular dependency 6 months post-ICU discharge. Sample size calculation was based on expected ICU admissions from first wave, spring 2020. Target: 500 patients. Aims: detect an odds ratio, OR, between 1.664 and 2.924. Assumptions: social deprivation rate, 50%, Ivoire cohort study. Respiratory sequelae rate at 6 months, 50% to 90% for ARDS survivors. Statistical analysis: data description was done by patient characteristics described based on deprivation status, categorical variables, number and percentage, continuous variables, mean plus or minus SD or median, Q1 Q3. Tests: CHI2, Fisher's exact, student T, or Wilcoxon tests, as appropriate. Results: study population. Total ARDS patients discharged alive, 4,529. Invited to participate, 742, 16%. Consented to participate, 543, 73%. Fully analyzable, 401 patients. Deprived patients, 160, 40%. Differences between deprived and non-deprived: gender, obesity, heart failure history, living status, income tax, education, and pre-COVID employment. ICU and post-ICU characteristics. ICU characteristics, similar between both groups. Respiratory assistance at ICU discharge. More frequent in non-deprived, 82% vs 72%, adverse events in ICU. No significant difference. Post-ICU rehabilitation. Similar for both groups. Prescribed rehabilitation at discharge, 30%. Actual post-discharge rehabilitation, 52%. No difference based on deprivation. Primary outcome was lung sequelae at 6 months post-ICU, 319 patients, 80%, deprived, 81% versus non-deprived, 78%. No significant impact of deprivation on lung sequelae. Adjusted analysis showed similar results. Secondary outcomes, respiratory evaluations. Deprived patients had more dyspnea, 66% vs 50%. Lower 6 MWT walking distance, 411 meters vs 444 meters. Slightly lower SpO2 at end of 6 MWT. More altered functional respiratory profile. Only FEV1 and FVC significantly lower in deprived patients. Quality of life. Lower in deprived patients using VSRQ score. Chest court and muscular dependency. Fibrotic-like lesions on chest CT, 37% overall. No significant difference between deprived, 33%, and non-deprived, 41%, muscular dependency. No difference between groups. Study overview. Largest multi-center cohort of COVID-related ARDS survivors to date. At 6 months, 80% had persistent respiratory defects. No difference in respiratory recovery based on socio-economic status. No difference in rehabilitation post-hospital discharge between deprived and non-deprived. Social economic status may not influence post-ICU rehabilitation access or compliance. Respiratory parameters used might not be sensitive to social deprivation. Potential limitations are possibility of selection bias, EPICES score validation and its reflection on vulnerability, socioeconomic deprivation evolution during the study, unique nature of the French health insurance system. The final conclusion was, no significant difference in respiratory sequelae at 6 months between socially deprived and non-deprived patients post-ARDS due to COVID-19.